All right, this is a lecture about documentation, which is not particularly my favorite topic. I would much rather talk about critical care. However, having seen many shifts where residents stay way beyond the end of their shift working on their notes, and having seen that those notes are still not that great, to be honest, I think that this lecture is necessary. All right? So I'm going to try to give you some tools to help you become better at documentation. Now, I do not consider myself an expert at documentation. I consider myself to be good, very good maybe at documentation. But I did learn from an expert. One of my attendings was like a quality insurance person for USACS, a big company, emergency medicine company. And he's the one who taught me to document. So I do think that I can give you some good tips that will help you become better. We're going to focus on three aspects of documentation in particular. So number one is becoming more efficient, or as I say here, reducing mouse clicks. Number two is getting paid. Now, I did not go into emergency medicine for the money alone. I went into it because I like the specialty. But if you're going to spend the time doing work on a patient, you might as well know how to document the chart so that you can get paid. And number three, protecting yourself. So it's protecting yourself medico-legally, but also protecting yourself from a peer review that may not necessarily be fair and otherwise, all right? There are other reasons to do good documentation for research purposes. That's one of my favorites. You can't get good research if you don't have good documentation for chart reviews. And also communicating with your colleagues. If you write an ED note, it'll probably be looked at by the inpatient providers, and it may guide their management of the patient, right? But we focus just primarily on the first three. So before I get into all this, you may ask yourself, why do you have to do all this nonsense? I ask myself that pretty much every shift. And the simple answer is that CMS, Centers for Medicare and Medicaid Services, has set up guidelines for how to document. They first came out in 1995 and revised in 1997, and they said this is what you have to document the chart for this amount of payment. And then the private insurance companies basically followed suit, and so they modeled their payment structures after CMS's. So most of the bad things in medicine come from CMS. This is similar. All right, so there's a good thing about this, though, is that enough people have complained over the years that this may change. And there was an article that I noticed, Annals of Internal Medicine from last year, that this is the first I'd heard of this, which is that CMS has decided that they are going to change the rules for documentation. It was supposed to start in 2019, but it's actually going to start in 2021. A little bit of a delay. And they're going to not force you to do all the crazy requirements I'm going to talk about, but rather to simply say how much time you spent with the patient, and that can be used instead of all the traditional requirements. But never is anything as good as it sounds, because guess what? That applies to office visits, but it won't apply to emergency medicine. So you will still, for the time being, do all of the things that I'm telling you about. All right, but if they're changing it for family practice clinics, internal medicine clinics, maybe down the road they'll change it for emergency medicine too, and we'll be relieved of all the crazy rules that I'm going to talk about. Okay? A lot of the rules for billing come down to $17.30. Does anybody know what $17.30 represents? I don't know what the hourly wage of the person checking your documentation is. Might be lower than that, to be honest. This is what it comes down to. A level 5 chart, which the CPT code is 99285. You do not have to remember that. I just call it a level 5 chart, is 3.8 work RVUs. Turns out I get paid, I think all the attendings do, I don't know everyone's contract, $13.75 per work RVU. I'll tell you how that calculates in a second, versus a level 4 chart, which is 2.56 work RVUs. So in other words, each level 5 chart, I make $52.50, and for each level 4 chart, I make $35.20. So all of the things I'm going to tell you is about how to bill or document your chart such that you will meet the level 5 requirements. And failing to do so will lose $17.30. That's basically the entire game of the documentation. Now, please never, never, never overbill the chart. Never try to over-document a bunch of things you didn't do. If you try to turn a suture removal into a level 5 chart, you will fail and you will have committed fraud, okay? So do not try to do that. But if you are working somebody up for a chest pain, for a headache, things where there are life-threatening issues on the table, your goal should be to build that as a level 5 chart. Any questions to this point? All right, before we get into level 5 versus level 4, etc., I have to clarify something. So a bunch of people have asked me the same question because apparently some people are told that you must do the click boxes in order to get credit for a level 5 chart. So logically to me that didn't make sense because every other EMR I've used you didn't have to click anything. So I didn't know why in Meditech you would have to. But I wanted to be sure before I told you the answer to this. So I emailed the director of documentation for Envision. Her name is Tia Curry-Cook. This is the exact email I wrote to her. I'm giving a lecture about documentation to my group of emergency medicine residents at Kendall Regional Medical Center. I want to clarify something to make sure I give them the right information. Some of my colleagues believe that you must document the history of present illness using the click boxes on Meditech. However, if the HPI and exam are written out as free text and all the necessary information is there, won't that work just as well? Anyone guess the response? Hi, Dr. Zidek. Both are acceptable. You just want to make sure all the documentation requirements are met. Okay? That's it. That is the answer. All right? Okay? All right. This is a very finicky projector, so don't make too much noise. All right? Okay, components of the chart. We're going to go through these each one by one, and I'm going to tell you what you need to do. All right? We start with the history of present illness. So again, the game here is for any complex patient to turn this into a level 5 chart. The good thing about HPI is that the level 4 and level 5 requirement is the same, and frankly, I don't even think you need to memorize anything here. But what you need are at least four HPI elements. I'm going to tell you what an element is in a second. The bar is actually low for a level 3. You only need one HPI element. I don't even know how you can do less than one HPI element, right? Like that's basically writing nothing, okay? So as long as you write something in the HPI, you're going to get at least a level 3 chart. All right? So what is an element? The elements are the things that you learned when you were learning how to take a history in medical school. So I don't know if you learned the OPQRST, the onset, as palliating, provoking factors, quality, region, radiation, severity, timing, and in addition to those, associated symptoms. Each of those things counts as an element. I'm going to give you an example to make it clear. So this is a supervisory note HPI that I wrote, and I will highlight the elements. So this is a 12-year-old male who was sent to the ED by urgent care for right-sided groin pain. I've listed the location of the pain. That is an element. He noticed some pain yesterday, but has been more persistent today. Yesterday it started. That's an element. The pain is of moderate severity. That's the level of severity. That's an element. Nothing seems to make it better or worse. I've said there are no, so that's an element. Actually, 2 elements. That's better or worse. 2 elements. So I already have 5 elements right there. Just for completeness sake and to make it better, I threw in a bonus. He denies abdominal pain, fever, vomiting, dysuria, penile discharge, or other new symptoms. That's an element. So I actually have 6 elements technically. I only put 5 boxes in this short HPI. And then for comic relief, I added the patient has had no known trauma, but the patient's mother reported that he was found to be experimenting in the bathroom recently. When asked about this, the patient did not clarify what he meant. I asked the patient's mother to leave the room, and I asked the child again, what was he doing in the bathroom? But he said, nothing. You may guess what a 12-year-old boy was doing in the bathroom, experimenting. So we will continue. All right. So review of systems. Review of systems is a very common one to miss the requirement for level 5 charts. In fact, at the former company I worked at, before I came here, I worked at USACS. and they would send something called coder comms, which is they noticed that you missed an important part of the chart that needed to be documented. They would send you an email and say, you please add an addendum to your chart to fix this. They don't do that here. But they did it at the other place to maximize their billing, appropriately so, I think. But the most common one was that not enough systems were documented. They'd be like, you only documented 8 review of systems. Would it be possible for you to add an addendum documenting 2 more systems? Okay, so you must have at least 10 systems reviewed if you want a level 5 chart. Comparatively, it is very easy to get a level 4 chart. You only need 2 systems, all right? But the 10 systems thing is what is going to get you. And I'm going to show you, I believe, on the next slide. Yes, okay, very good. On this slide, you see that there's this all systems reviewed and complete systems reviewed. Actually, if you click those, that's going to count for your 10 systems reviewed. Okay, so I noticed that all of the residents click all the individual systems. You can do that, and some people might even tell you that's better. However, it takes me too long. I don't do that, okay? It takes a long time to click all of these systems down. All right, you need 10. So, and let me clarify though, if you write a free text HPI and you write at the end some negative things, which I think you should, that's a good way to do an HPI, like no fever, no cough, no, those there count as systems. So technically you could do those and then list some individual ones, but you want to make it easy on yourself, just always click the all other negative and complete review systems negative, okay? Save yourself a ton of time. Now, the way I learned to do review systems is because I learned how to document dictating. So I used to speak my entire note into a phone. I was taught to say the phrase, a 10-point review of systems was performed and all were negative except as stated in the HPI above. So on 100% of my charts where I was trying to build a level 5, I said the exact same thing. And that's what I was taught. That covers you every single time, all right? So if you go somewhere else and you don't have Meditech, say something along those lines, that you performed a 10-point review of systems and it's all negative except as what you stated in the HPI. All right? So this basically eliminates review of systems as something to worry about, okay? Anybody have any questions about that so far? Yeah. Yeah.
What are the chances that if we start doing this, this is not as widely accepted as outside of this group?
110%.
Right. Okay. So I know that there's local things like you must click the click boxes. I'm telling you, this is what CMS says. This is what our Envision says. All right. I'm telling you what the big governing bodies. You work as a resident. You need to follow what your individual attending says. I personally have never once clicked one of these boxes. I've never done it. All right. And when you become an attending, I recommend you don't individually write out the review systems. It's going to kill your efficiency. It takes too long. Nick. Okay, so one, what you're doing now is probably already potentially going to hurt you, right? So the entire view of systems thing is so egregious, right? Because proper emergency medicine may not dictate that you really do a 10-point review of systems on every patient, right? Like, do I do 10? I don't know, maybe. I don't actually count how many systems I do on every single patient. I do the most thorough history. I do a very thorough history, and I ask all of the pertinent questions. But I'm not sitting there like, oh, good, I've asked all my 10 systems now, right? Nobody I've ever met who sees patients does that. That's an insane thing to do. And frankly, review systems should just be completely cut off. This is a crazy thing. We're all just doing it just to meet the requirement. Okay? So, could you, if you document all negative but they had abdominal pain, like come back to haunt you? I don't think so, unless like the nurse documented that the patient had abdominal pain and then you didn't, right? Then maybe. But in general, that doesn't come up very often. Yeah. This is an example of a resident chart, by the way. This is when the attendings look at the chart, like it's like a little grayed out. You see this, how these are grayed out? So this is an example of a resident chart. 1, 2, 3, 4, 5, 6, 7. And then these are all not documented, right? So this chart, unless they put in their free text HPI 3 other systems, which maybe they did, maybe they didn't, this would have been billed as a level 4 instead of a level 5, just based on that by itself. Yeah.
But if you would have checked the box at the top and done like 4 there, you'd be good.
you would have been good to go. Yep.
Do you have like an end in your HPI patient denies any other symptoms at this time?
That doesn't count. You got to specifically review the systems or say that you reviewed all the systems and then they were negative or accepted what you stated. Okay? You can't just say patient had no other symptoms. Doesn't count. Okay? Anything else on this before we move on? Past medical history, family history, social history. Bar also pretty low here. Level 5, all you need is 2. You need to list 2 out of those 3 things: past medical, family, or social. My opinion is family history is usually not relevant in emergency medicine. In some cases, yeah, like chest pain, working for coronary artery disease. But I don't ask family history on most patients. So for the vast majority of patients, I'm documenting past medical history and social history. All right. You're welcome to document all 3. And if you're an intern, I recommend that you document everything just to learn how to make sure you're consistently doing a complete history. As you get over time, you may decide to cut off some parts of your history for efficiency purposes.
Do you know
Yeah.
if when we're filling out like these little, they got the...
So, yeah, technically, if you have the past medical history listed in the chart, you could argue to level 5. I mean, you could level 5 bill it. But the problem is, if you're starting to put things that are not where they belong, then the coder may miss it. Okay, but if you were ever sent the chart being like, hey, look, you didn't document this, you could be like, no, actually I did, it was just in the HPI, right? So, but avoid that problem altogether and just put the past medical history in the past medical history section. Okay, Clemens.
So if like my introductory symptoms in my HPI is like a 60-year-old non-smoking male with past medical history,
Again, same thing. Yeah, technically they're listed to past medical history and social history, and that would count. However, don't make it hard on yourself, because the biller, again, the person looking through your chart may not catch that there, all right? And they are only human. So make it easier on themselves and put the past medical history in the past medical history section.
They have no incentive to go try to get you better billing.
Right. They do this all day, every day. I'm sure they don't want they don't want you making this as hard on them as possible, all right? Start putting the medical decision making in the HPI and the exam, and then, I mean, right? Don't do that. All right, I got to move on. We're taking too long. Okay, here is an example of a resident chart. Here is the past medical history documented. By that I mean no past medical history documented. They documented one thing. They documented drug use. Probably they didn't ask them the drug use. I got to say, if you documented only drug use, they probably just guessed that the person doesn't use drugs. All right. Auto-populate. All right. So again, here you go. Just by this alone, you can't build this as a level 5 chart. You got to have something in the past medical history. All right. And you guys are residents. You should be asking every single patient what their past medical history is. That's a pretty basic question in history taking. Oh, good. You have hypertension. All right. Boom. Okay. Physical exam. Physical exam, there's a little bit of variability depending on the source that you look at. And that's because CMS guidelines are slightly conflicting about how much you have to put for a physical exam. So I will recommend 9 organ systems for physical exam, because I think that will cover you in all cases. If you do 9 organ systems, you should be able to build a level 5 chart. A level 4 chart simply requires 5 organ systems. So I think the 5 here is worth noting, because something like an ankle injury where doing a full exam probably isn't warranted. You probably should at least try to get 5 physical exam findings there to get a level 4 chart out of that. So the focus physical exam part. So this is actually one of the templates that can screw you. All right, this is, I believe, the urinary or something template. You look at this template, and it only has 4 things in the main physical exam part. I just said you need at least 5 things to even get a level 4 chart. And I will see occasional resident charts where they only go to that part, but you have to click this green thing here, and it opens up the additional physical exam. So this is an example of a resident chart. They did the templated recommended for, but they didn't do anything else. So they only had 4 physical exam systems. So that wouldn't even be enough to build a level 4 chart here. So what you would wanted to do here, if they were here for like flank pain, which is oftentimes what people, that should be billed as a level 5 if you're, unless it was complete nonsense, like someone tapped them in the flank or something, right? But if it was like non-traumatic flank pain, you should be billing that as a level 5 chart. That's a complex patient. So you need to go down to the additional physical exam and give yourself 5 more systems in addition to those 4. Questions with that? Yeah.
I can look at Tony and see that he's not tachypnic and I can see he's not nasal flaring, there's no skin rash. I can do a level 5 exam sort of by
Yeah, so that's why, honestly, you should always be able to get at least 5 systems out of someone, right? Like Jen's normocephalic atraumatic, trach midline, neck during exam was supple, right? Neuro exam, she's alert and oriented, her speech is normal. I can do a bunch of systems just by looking at a person, right? Yeah, right. So there's no reason that you shouldn't have at least 5 systems on every single physical exam. All right, let's continue. So I think that the 2 key numbers here are the 10 review of systems and the 9 physical exam systems. Do those on every patient that you see that's not fast track level. Chest pain, headache, abdominal pain, neurologic symptoms, you need those things. Questions? All right. Medical decision making, by far the most complicated section. So in order to build a level 5 chart, you need what is called high complexity. The way that this is judged is too complicated for me to try to teach you in this short talk, but it's okay. I'll give you the rough idea of how it should work. All right? So some of the things that are considered are the number of diagnostic and management options that you mention in your medical decision making. All right. I'll just show you on the next slide, actually. It's going to be easier. And then second, the complexity of the data analyzed. And then there's also something that's risk. In other words, is it seeming like you're dealing with someone who has more risk of decompensating? These are quite subjective, I've got to say. And it has been looked at that even if you look at 2 different coders, billers back to back, that one would have slightly different interpretation of someone's medical decision making than another. So your goal is to just make all your level 5s appear to be as complex as they should appear to be, all right? You should not make it look like they were less complex. And so here's how you're going to, some of the ways you're going to make your chart look complex, okay? So this button here, considerations. You see these 2 things, independent review imaging, reviewed prior records. I notice some residents click these all the time. In fact, some of them click independent review imaging when there's no imaging. That's poor form, all right? But if you actually look at the image, click this, click this. If you actually review records, click this. Why? These are going to contribute to your complexity of that chart, all right? If you don't do those things because maybe you didn't get imaging or maybe they have no prior records, it's okay. Many other ways to get complexity, but one easy way to get complexity. And if you don't have Meditech, you should learn how to free text this into your MDM. So you might say, upon review of prior records, patient's hemoglobin was noted to chronically be low. Hence, anemia is chronic, something like that. There you go. You're going to add complexity to your chart. Or chest x-ray was performed, which I reviewed myself, and shows pneumonia. See how that works? All right. That's how you're going to add that in free text if you don't work in Meditech. These buttons here, these lab and imaging, there's also going to kind of be the same idea. You click these, and it's going to say that you reviewed the lab stuff, and it's going to help add complexity. And this is an unfortunate issue with the way that charts are built, is that adding more tests will basically increase your complexity. And that's not fair to me because, like a vertigo patient, I'll usually order nothing. And yet someone else will get a head CT and a whole bunch of labs and an EKG. Their chart can make it look more complex. So what I have to do to make up for that is write a longer free text medical decision making about how I excluded everything with my physical exam and history, right? And I can still get that to be a level 5 chart, but I have to work harder to do so. If you just order a bunch of tests and you're like, look, I looked at all these tests, then it'll seem to somebody who doesn't understand the medicine that that's a more complex patient. And we were both dealing with a vertigo patient. You follow how that goes? Oh, yeah. Yeah, Capelli.
Once it's for, talked with family, talked with consultants, talked with this, and it has more options actually to make your chart complex.
Right. So these I tend to not click that much. So this is actually a myth that I learned in doing preparing for this lecture. So the pulse oximetry, I was taught incorrectly, can be billed as an RVU procedure. Not true. Can't. I looked it up. It's listed under the RVU procedures as 0 RVUs. I'll show you that later. So there is a reason that you might click this. So this can add to your complexity. So if you have a patient, for example, an asthmatic, who you don't get a bunch of tests on, I would document a pulse ox because it's like you use that as part of your decision making. So documenting a pulse ox can increase your complexity, but it cannot be billed as a separate, does not add to your RVUs for the chart directly, only indirectly by helping you get a level 5 chart. In fact, if you document a pulse oximetry on an ankle sprain, it does 0. So I know that you guys are taught to do it on every patient, and if you want to be sure, you know, that it counts every single time, go ahead and do it on every patient. I don't. It's just an extra thing to click that doesn't add anything to the chart in the majority of cases. In fact, ACEP has its own page about can you bill for pulse oximetry interpretation? It goes like, no, you can't, and blah, 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 and explains all these reasons why.
The rhythm strip.
Great. The rhythm strip you can bill for. Believe it or not, I'm going to show you RVUs for specific procedures later, but counts as 0.15 work RVUs, which is like $2. So if you did that on every single patient, the issue is there are cases where you can't get an EKG and a rhythm strip. That's too complicated. I don't know when you can do both and when you can't do both, because if you do an EKG, you might not be able to get the rhythm strip. But if you did this on every single patient, you probably would increase your RVUs. The pulse ox, you're not going to increase your RVUs, likely. Yeah.
What if it's what if you look at the monitor, you can document that as a rhythm strip?
You can.
EKG is billed by cardiology.
Yeah.
You don't get billed for that. Have a look at the monitor.
Yeah, the EKG billing is too complex to really get into this in this lecture. Depending on where you work, it can be cardiology, it can be you, it can sometimes be both. If you have you should document a full EKG read, all right? Just because it's the right thing to do for the chart. How it gets billed here, it's too complicated. But the point being, yes, you can get RVUs for rhythm strip interpretation, which is just looking at the monitor. In some cases, you can get separate RVUs for an EKG interpretation. In rare cases, you can get both at the same time, but in most cases, you cannot. Yeah.
When you see critical care, EKG, you were getting some RVUs for that, but pulse oximeter was
0. 0, yeah. I was taught it wrong. Like literally until I prepared for this lecture, I thought that I was getting RVUs for that. And I was like, I just wasted so much time in my life clicking that stupid pulse oximetry box. All right. Common question, I didn't have it below, but below this EKG, you'll see all the individual lab interpretations, and the scribes will click CBC normal, blah, blah, blah. Boris was asking about this. So again, if you click all that, it can increase your complexity. However, for my money, it ain't worth clicking all those individual boxes. I don't do it as an attending. And it increases your complexity, but you can probably regain that complexity if you write a good free text medical decision making, which is going to be worth a lot more as far as protection. All right. So if your attending tells you to click all those individual CBC interpretation, fine. You certainly don't have to do it with me. And when you become an attending, I recommend that you don't, because it just takes too much time and adds very little. All right. Now I'm going to give you some examples of medical decision makings. I apologize; these are from you guys. If you read it and you know it's yours, you can say it, or you don't have to. Nobody will know. So does anybody want to volunteer to interpret this first one? I just want to see what your impressions are before I give my Capelli. All right, very good. Good, Capelli. So here's a medical decision making from this is a Qingdao special. Chinese New Year edition beer from China. So, so this is a free text medical decision making from one of your residents. I'm not saying these are the worst I've seen or anything. I just literally randomly selected them within the last month as I was preparing for this, okay? 39YF presents with vertigo and multiple episodes of vomitus, patient non-toxic appearing with unremarkable vitals upon presentation, patient with normal gait and no focula. Neurologic deficits on exam, symptomatic meds administered, CBC revealed hemoglobin of 9.9, baseline 10.9 on chart review. EKG unremarkable, count unremarkable, patient tolerating PO prior to discharge. Your general assessment of this MDM Capelli.
Okay, I mean, they're mentioning the treatment, like they're telling you examination findings and then a little more details about what was specifically given.
Okay. Spencer, you have a different comment on this?
As always with emergent medicine, rule out the bad things. So I would want to prove to whoever's reading this in the future that this was not a stroke.
All right. Very good. So I actually sort of disagree with Capelli's assessment of this chart, and I like what you're thinking here, Spencer. Okay, so
I would only include the things that are relevant to that decision. Like I wouldn't even bother putting the CBC or
okay. So this is going to, the way I'm going to teach you this, one, it's going to speed you up, and two, it's going to help protect you. All right? So number one, 39-year-old female presents with vertigo and multiple episodes of vomitus. Medical students are taught to give like that first introductory sentence in their MDM, and you can do that if you want. However, I don't, right? Because that's already in the chart. See HPI above, right? That's what I mean, I don't say that, but if you want to know what they're here for, it's already there in the HPI. So I personally don't write that first sentence anymore. Now, stylistically, if you like the way it flows, go ahead and do that. But for me, I'm writing thousands and thousands of charts and MDMs. I don't like to write that, okay? Second line, patient non-toxic appearing with unremarkable vital signs upon presentation. So that's a physical exam finding. Hopefully, you can look back and see what the vital signs are, right? You don't have to write what their vital signs are. Now, I will comment on the vital signs in a MDM if I'm using it to say a point, like, patient with fever here, however, vital signs normalized after Tylenol. I'll say something like that, thus patient safe to go home, right? I'm using the information to make a point, but I'm not just putting something that's already in the chart elsewhere again in the MDM. That doesn't add anything to the chart. It's just repeating something that's in the chart. Next line, patient with normal gait and no focal and neurologic deficits on exam. I'm cheesing the person who did this because if you have a lot of grammatical and spelling errors, to somebody who's like, if this were to go to court, they'd be like, man, this doctor's kind of an idiot. Like, why can't they spell? It's not that bad. It's just that one thing, right? But you'll sometimes see people's charts that have like all sorts of spelling errors. I'm like, good God, what if this were to like be reviewed? That was so embarrassing, right? So just recheck real quick before you click submit that your free text generally looks like it has decent grammar and spelling, okay? But the other point here is normal gait, no focal neurologic deficits on exam, same thing. You already should have documented a neurologic exam above, so that didn't add anything to the chart. Symptomatic meds administered, you can find on the chart what exactly was administered. You might say, after symptomatic treatment, patient's pain resolved. That is useful, but just saying symptomatic meds administered adds nothing to the chart that wasn't listed somewhere else. CBC revealed hemoglobin 9.9. This is good. Look at that. Now they have a comparison. So if they didn't click that little button of prior reviewed, they've increased their complexity there, all right, by comparing to a prior chart. So that's good. I like that comparison. But saying EKG and chem unremarkable doesn't necessarily add anything unless, again, you're trying to make a point with it. Like EKG not suggestive of arrhythmia that might explain patient, I don't know how that could even explain vertigo, but EKG not suggestive of arrhythmia that could explain patient's symptoms. I like that. But just saying EKG unremarkable, you've already documented what the EKG says, so you haven't added anything. You see how this goes one line by line, and how when you get down to it, you're like, this thing didn't say anything that didn't show up somewhere else in the chart. All right? So Spencer, you would have spent more time saying why it's not a stroke, right? Because we didn't test them for a stroke. We didn't do a head CT. We didn't do a brain CT, right? So then that would have been a better way to spend your MDM time. Yeah, Anna, you had a question? Exactly. Number 2, who wants to critique this one now that I've taught you how to critique one? I'm going to show you mine after a couple resident ones, all right? All right. All right, number 2. Anybody want to, Pavel? Here you go. That's the back to Pavel. No, you're ungrateful. Jesus. All right.
So I think there are some good and then kind of redundant components that we talked about.
Okay, so Pavel says for the recording there's some good things in here. So tell me some of the good things that you see.
So they address the complaint why they don't think it's dangerous. They say why it's not ACS.
Good. Yeah, I think that's a nice thing to write in there. that this is unlikely to be ACS with those reasons. I like that. Good. Keep going.
But then, restate physical exam finding and lab findings, which we talked about.
Right, and I've seen, yeah, and there we go. This is again, you already just documented a physical exam, and now you're documenting your physical exam again, and including it, you wrote neuro intact twice, and you spelled benign wrong. So not only have you not helped yourself by anything to the chart, but you've made somebody who's like, man, this person's not very good at English, right? So you haven't helped yourself. You might have hurt yourself there. What else, Pavel?
I do think they started with a good thought, not worse headache of life, not that. They didn't say why that's, they didn't really specify, so I don't think it's subarachnoid.
Right. So how would you have reworded that then?
Don't suspect subarachnoid based on this, and this.
Love it. Yeah, exactly how I would have worded it. Subarachnoid hemorrhage, very unlikely here, as patient has normal neurologic exam and doesn't have the worst headache of their life, right? Doesn't that sound pretty, all right, it's not a subarachnoid hemorrhage, okay?
They said they gave it treatment, and their symptoms resolved. They didn't say they gave it treatment.
Yeah, so you like that part. I like that part too. Although you could also put that in the re-eval area, and you don't have to do both, right? Again, so you don't have to do both. Save yourself some time. Don't double document. But that's good that they mentioned that their symptoms resolved. I like that.
The last line, I think is good as well. Besides the typo, but I always write that.
Yeah, no, you don't have to say necessarily that you discharged them, because that's going to be evident in the other part of your chart, right? It's going to be disposition, dispo. But you might say something along the lines of, given these findings, patient is safe for discharge. Like you're making an assessment there, all right? But you can write planned DC home if you want. It's just probably not necessary. Yeah. Okay. All right. Not too bad. Good job, Pavel. All right, one last one. I'll do this one for you. 81-year-old female with a past medical history of Alzheimer's presents via EMS for generalized anxiety since the AM. And then they just list EKG, sinus 77, ST changes, no acute process, CBC troponin within normal limits, CMP elevated, creatinine, lipase with a normal UA negative, chest X-ray, no acute process, CT abdomen pelvis. All right, so before we get down to the bottom part. So again, this patient, they put the line, that's fine. If you like stylistically to do that, you do. My personal preference is not to waste the time. All right? But they put that they presented for generalized anxiety. Look at this workup. Does that workup fit with anxiety? That's pretty weird, right? So something is amiss here, all right? So if you're going to order a CT scan of the abdomen on someone with anxiety, that may be indicated. But it may be indicated because they're not just there for anxiety. They're there for abdominal pain and anxiety, right? So I like when I'm ordering a CT scan, especially if it's negative, to say why I ordered it. Because then I'm listing some sort of differential diagnosis, I'm adding complexity to the chart, and I'm saying that I ruled things out. So I might say something along the lines of, although patient presented with anxiety, also complained of abdominal pain, so CT scan of the abdomen was ordered to assess for appendicitis or diverticulitis, but no abnormality was found. All right? See, here, we're simply just listing out the results when the results are already evident in the chart. So you're not adding anything to the chart. And really, the workup, somebody could say, this just isn't congruent with what you said for the top of this. So it doesn't make all that much sense when you look at it. Yeah, Ramsey. I think that's a good practice. So having a differential diagnosis is essentially mandatory to build a level 5 chart, all right? So one of the ways that you're judged for complexity is to list several diagnostic considerations, all right? But the way I like to do it is to say it's not something, right? Rather than to just list it on that click box thing. So I'll often say, acute coronary syndrome, going back to the last example, very unlikely due to atypical symptoms and lack of cardiac risk factors. I haven't just listed, acute coronary syndrome by a click box, but I've said it's not this, right? Or if I find something, I can still list a differential diagnosis. Like I like to write this one for appendicitis. I'll say CT scan demonstrated appendicitis without abscess and without clinical signs of sepsis, right? So I found appendicitis, but I'm still demonstrating increased complexity. And if the patient decompensates, I'm saying, look, right now they don't have a perforation. Right now they're not septic, right? Do you see how that works? That even when I find something, I'm still saying it's not something worse. Okay? Yeah. The more, so this is again where it gets pretty complicated. If the more things that you can discuss, the more management and diagnostic options you discuss, the more complexity your chart has. But all these people who you're ordering CTs and labs on, you're likely going to have enough complexity to get a level 5 chart. And I mean, I wonder if if you just write nothing, you might somehow still get away with it if you click a couple boxes. All right? But you should be a little bit better than that by, I recommend, doing a free text MDM in the way I'm telling you to do it. Okay? All right. So this is an example of one of my free text MDMs. So this one's longer, actually, than what I usually write. I'm going to show you a short one later. All right? But this patient came with abdominal pain. That was already evident in the HPI. That's right, I didn't write patient here for abdominal pain. I wrote CT scan ordered to assess for bowel obstruction, biliary disease, diverticulitis, or other intra-abdominal pathology. No acute abnormality found to explain his symptoms. Incidental finding. Radiologist commented on vertebral body lucencies. Uncertain cause. Discuss with patient and son. Recommend a follow-up with primary care to rule out cancer. Very common error I noticed in resident charts. Incidental finding not mentioned in the chart. All right? So you order a CT scan, you good, you didn't see anything acute, but you found that early cancer, that's going to be your lawsuit in 10 years. All right? So every time that happens, you document that you talk to them about that. And this is what I was told by the guy who I said was the expert who taught me. I don't know if this is actually necessary, but he said to specifically say to rule out cancer. Because there's been some lawsuits where someone was like, oh yeah, they told me about that pulmonary nodule, but I didn't know it was going to be a cancer. I would have followed up if it was cancer. But if they would have told me that it might be a cancer, I would have followed up. And so then they'd blame it back on the physician. So I write that phrasing a lot. I specifically say, I'll tell the patient, I'm not going to flip them out, right? Because the pulmonary nodule in particular, it's not something to flip out about. Be like, the reason that you should follow up for this is that in rare cases, these are an early cancer, all right? So that's why you should follow up for this. And boom, now I've told the patient they could have cancer. And so I can document that they could have cancer. All right? Second paragraph. This is my lab interpretation part. Lipase was normal, making acute pancreatitis very unlikely. I've ruled out appendicitis or almost ruled, not appendicitis, pancreatitis. All right? And I write that I almost write that in almost everybody that I write to get a lipase in, just because it's a direct test that tests for a specific disease. That's my interpretation of that. And LFTs were not suggestive of hepatitis or biliary disease. This may have been overkill since I got a CT scan on this patient, to be honest. But I realized after I wrote this one that I wrote a lot, going through kind of a lot of the things that I do, so it would be a decent example for you. Patient's pain could have been from constipation. I'm not saying it's definitely from constipation, but I'm proposing what I think may be what's going on. Just so if somebody looks at this chart later, they're like, oh, this probably was just here for constipation later. And then when they come back in a week and the abdominal pain, they don't find anything again, they're like, oh, 2 times, maybe it's just been constipation. Then we can come to a conclusion. Maybe it was just constipation. Patient already has Miralax at home. This is good. If you don't write them any prescriptions, you want to know why. That way Averbach's like, you discharged this patient who bounced back because they didn't give him any prescriptions. Well, I already said this patient has Miralax at home. So I'm going to tell them that that's what they should use. Again, you guys are pretty good at this, that reassessing their pain. Patient pain had resolved at time of discharge. And then here's the subtle one. You're discharging abdominal pain patient. This lady was like 80-something years old, right? So abdominal pain can sometimes be from coronary artery disease in elderly patients. Oh, his EKG showed no acute ischemia, and constipation is much more likely explanation of his pain. All right, so if that patient comes back dead in 2 days from an MI, at least I've addressed it. All right? So could I still get sued? Sure, you get sued for anything, right? But a lawyer looks at this chart and is like, well, I mean, I don't know what else you could have done, right? Admitted them for constipation. That would have been what you did, which is unnecessary, right? So, do you see how this is different than the other ones? Yeah, Spencer. Yeah. That's fine. But I would also add in, you can, I don't know the local department policy. I've been told not to do that too, but I do it all the time. Yeah. On the discharge instructions, it has a link to get the results, right? So you can also link them to that. But I would specifically talk to them about it and why they need to follow up, right? Okay, and if it's something that is more pressing, mention that that's what it is. All right, like you need to follow up for this reason, and you can document that in the chart. Yeah. Good. Yeah. Good. Yeah, and if you just want to, if you do that, that's probably sufficient. All right. Yeah.
Choose to address AAAs and dissections in the abdominal pain, low risk doesn't seem like it is.
For triplet, yeah. So if for some reason I thought that was a possibility and I hadn't done a CT scan, I've done a CT scan on this patient with contrast, I believe. So you've sort of taken dissection and AAA. You've made those very unlikely in this case. You can go all day. I mean, I could write a 2-page MDM on every, and this is longer than what my normal one is. I'll write longer ones if the patient's higher risk or if I think we fucked up something. All right, I'll write longer ones, and I'll write shorter ones if it's very straightforward. I'll show you another example. All right, almost done here. Sorry, guys. So here is one recently 61-year-old male who remains stable with ongoing pain. So again, this one, the resident didn't do the first line summary, which is fun, I think. But this happened to be back pain, by the way. So remains with ongoing pain, negative CT evaluation for acute process, no neurologic deficit noted, admitted for pain control and further evaluation. Okay, so this one here, it doesn't really have a differential diagnosis. So you might get into some problems with complexity if they're just for back pain, but they ended up admitting them and you got a bunch of tests, you might get away with sufficient complexity. But you would have been much better off to list what you were looking for on the CT. Like you might have said negative CT for acute fracture or something like that. At least you would have listed something that it wasn't, okay? No focal neurologic deficits. Again, you've already documented a neuro exam, hopefully, so you probably didn't need to write that, but you could have said no neurologic deficits to suggest Cauda-Equina syndrome, right? You see how that's different. Admitted for pain control and further evaluation, fine, all right? So, but you could have done this in this very short paragraph saying, I mean, because this is short and that's fine. You could have done this, showed a little bit more complexity, ruled out a couple more life-threatening things if you just added a few other sentences or a few other phrases. So this is the same patient. This is mine for that same patient. Patient symptoms not consistent with Cauda-Equina syndrome. Screening labs for atypical presentation of spinal epidural abscess were negative. Lumbar CT showed chronic changes but no fracture or acute abnormality. Patient reported he was in too much pain to go home, so he was admitted for intractable back pain. All right? So this is a short one, and this is how more of my MDMs are. But look, I've addressed these life-threatening threats. I've said that they're not that, and it flows as to a logical course of actions, I think.
You didn't get the
Yeah.
gold standard for Cauda-Equina syndrome here, right? You're okay with that?
Yes, because I've also paired this with a good neurologic exam and a history that says no urinary incontinence, no urinary retention, no fecal, right? So if you do this and you're going to say that the symptoms aren't, you need to be able to say, look, refer up to my symptoms that I documented in my HPI, which none of them are Cauda-Equina syndrome except for back pain. And so someone would be like, you're right, it's not Cauda-Equina syndrome.
Feedback,
Yeah.
at least I got
Yeah.
as an intern, was take more and more out of my MDM
Mhm.
because I wasn't getting the gold standards.
Yeah.
I think it's gone now, but like
Yeah. No, so
my MDM says only
I understand the concern is you don't want to say like, look, this patient might have Cauda-Equina syndrome, but I don't think it's Cauda-Equina syndrome, so they're going to be fine, right? You don't want to sound like that. What you want to say is like, look, I didn't need to do the advanced test because their presentation doesn't fit with that disease, right? And if you're documenting a good history and physical above it, then it's going to be clear to someone with any medical knowledge and logic that you were right in that case, okay?
The standard of care, if the patient has a neurological finding, then you would have to order imaging, otherwise back pain can be treated symptomatically without imaging at all.
Yes, so this is a more complicated issue, which of course we can't address in this short lecture. But if someone has something and you still don't want to test for them, like let's say someone's not PERC negative and you don't want to test them for PE still, you can do that as long as you're right, right? You can do that. But if you're wrong and you've gone against like an evidence-based rule, or you want to ignore urinary incontinence in a back pain patient, you can do that, but you better be right. Okay? So you need to have an extra level of confidence to do something like that, which I'll do sometimes, but I'm just very careful when I do it. Yeah. Yeah. Right. Right. I mean, weird shit happens. You can't document, to exclude all possibility of all outcomes in the future. People are going to die at some point, 100% mortality. Yeah.
The thing that I do see though is that someone will say, patient with no fever, do not suspect epidural abscess, right? But they might have other risk factors. So you see how his says patient presentation is not consistent with.
Mm-hmm.
Should this be an atypical presentation, even screening labs are negative, right? He's not committing himself to everything. So unless you're going to name all the common things like patient with no fever, no midline spinal tenderness, no neurologic deficit, good sensation, no urinary bowel incontinence, unless you're going to list the most common presentations or red flags for that disease and then say it's not consistent with it, I would recommend you choose to do all of those things, which you probably should do if you're more of a resident, versus saying one risk factor and saying patient doesn't have fever, do not suspect epidural abscess.
Yeah, excellent point. Yeah, the reason that mine works is, again, because it's coupled with a thorough history and coupled with a thoroughly documented exam, right? If I said this, but the patient actually had like saddle anesthesia, and I haven't mentioned no saddle anesthesia later, than be like, dude, it was consistent with caudate equina syndrome. You were just lying on your chart. They had saddle anesthesia, right? So it's got to be coupled with an appropriately documented HPI and exam. All right, so we are running behind, so I'm going to speed this up, mention a couple things about procedures. This is my favorite procedure in the ED. I don't know what this one's called or how many RVUs you get for it. All right. I did something similar to this recently, yeah, but it wasn't quite this one. Yeah, yeah. Okay. I mentioned laceration in particular because it's a rather high risk yet common procedure. All right, so this is the documentation from one of the residents regarding a laceration that they did. Anybody want to just say what they think about it, this documentation? It's actually not that bad, but there's a couple points I want to make.
Actually, it's kind of a question as well as an interpretation.
Yeah.
Somebody told me that if your wound length is 2.5 or above, there's like an additional RVU.
That's correct. I'm going to show you some specific RVUs if we have time here shortly. But the laceration lengths are billed by, the laceration RVUs are determined by the length of the wound, and there's intervals. 0 to 2.5 is the lowest interval. Once you get above 2.5 centimeters, you get into the next level of RVUs and get paid more. So that's different. So lacerations are also billed based upon what's determined to be the complexity of the wound. So if you have to do multi-layer, specify that, you can get a more complex wound, you can get paid more, because there's simple, like intermediate and high complexity. Okay. Another way to increase your complexity besides multi-layer closure is mentioning that the wound was extremely dirty and you had to spend a lot of time irrigating it out and cleaning it. All right, that can get you up to an intermediate level complexity laceration too. All right, so but what else you're going to say, Capelli, since you started about this laceration?
You already mentioned one thing, which was layering, whether it was a dirty wound, whether you had to debride or undermine, whether there was copious bleeding or not. You want to mention the result of your intervention. So if you already put in 6 sutures, how did things look after?
Okay.
Was there no more bleeding? Was it well tolerated? And also, which type of material, like whether it's Proline or not, Ethelon.
Good. Yeah, I would have done all those things as well. All right. So this is actually sufficient to get for billing purposes. This laceration would get billed. It'd get billed as a simple facial laceration because the location of the laceration also depends on how many RVUs. Face is worth more than extremities and so forth. Okay. So this is enough. This is enough to get paid, but I don't think it's enough to protect you. All right. So you must mention something about foreign bodies in lacerations. And the reason I chose this one in particular is this patient had a foreign body. All right, and I knew they had a foreign body because they got a CT scan of their head that showed a foreign body. And so I personally removed it, so it was fine, but I went back and I looked at the resident's note who mentioned nothing about the foreign body. And so I was like, from the outside, although I know that I got the foreign body out, from the outside, it looks like we just left the foreign body in this patient, as all we see is a CT scan of their head that shows that there's a foreign body, and we have a laceration repair note that mentions nothing about a foreign body. So every single laceration should say explored wound and no foreign body found, okay? Every single time. And if there is a foreign body, you better mention it. You can't leave that out. I like what Capelli's saying with regards to mentioning the type of sutures. That is not essential for purposes of billing. But for purposes of follow-up, when they come back, it's nice to know if they had absorbable sutures, if they didn't have absorbable sutures. All right. We're going to move on because we're running behind. Here is a procedure note. Pretty light. Paracentesis performed at 1320, 2.2 liters drained, patient tolerated procedure well. All right, so in the interest of time, I'm just going to tell you that this is maybe sufficient for billing purposes, although you should specify a few things like ultrasound guided or not ultrasound guided. For protection, this is definitely not sufficient. I recommend that you document procedures assuming there's going to be a complication, because you're going to have complications. If you do procedures, you're going to have complications. So you document every procedure, assuming there's going to be one. So how did I document this? When I saw the resident documented this, this is what I wrote. I wrote an ultrasound-guided diagnostic. And by the way, I have templates for procedures. So if you have common procedures that you do, you just can copy and paste it right in. You just change a couple things, okay? An ultrasound-guided diagnostic and therapeutic paracentesis. So I specified ultrasound-guided, which bills more than a non-ultrasound guided paracentesis, okay? So I've increased the billing from whatever her RVUs were for just saying paracentesis to a little bit higher by saying it's ultrasound guided. After discussion of the risk benefits and alternative, the patient signed written consent. Nothing about consent. Was there anything about consent? Yeah, nothing about consent in that other note, all right? So what if the patient was like, I didn't want them to do this, right? Okay, hopefully that form that is in the chart that was signed is there, but I don't trust much of anything, right? So I would definitely mention that the patient gave you consent in your procedure note. The positioning, this may be overkill to say. You probably know that they're in a supine position, but that's how my template says it. Ultrasound was used to identify a spot, and then I see either says right lower quadrant or left lower quadrant here, where there was sufficient space. The site was marked, prepped with ChloraPrep, draped in the usual sterile fashion, skin and subcutaneous. Skin was anesthetized with 1% lidocaine, skin neck. This is basically the details of how you do a paracentesis. You read this and you're like, these are the steps to follow to do a paracentesis. All right? And then at the end, I say, I tolerated well, no complications. All right? So I have given a detailed description of the procedure, which again, I use from a template. I recommend that you do the same thing. Writing this little, and if something happens, is going to put you at risk for peer review, for lawsuit, for something like that. Questions about that? Okay, the last bit here, money. So everybody likes making money. Again, I'm not in this business to make money, but it is worth knowing roughly how much money you can make from doing certain things. So I'm just going to randomly show you some common procedures and how much they will make you. These are all based on work RVUs. Some people just call them RVUs, and that's fine, but they're technically work RVUs, relative value units. And that's what this number is here, 0.17 for an EKG interpretation. Whether or not you get that in our hospital every time is unclear, but if you did, that only gets you $2.06. All right, that is based upon the $13.75 per RVU that I make in my contract. Laceration, we just talked about this one, less than 2.5 centimeters on the face, that's 1.07. You can get yourself $14.71 for that. A short leg splint, someone's got an ankle fracture, is going to get you $10. Critical care time. By the way, critical care time, you must do at least 30 minutes of critical care time in order to get any critical care time. If you do 25 minutes, sorry, no critical care time. So the minimum is 30. And then the next interval starts at 75. So you got to do over 75 to get into that second category, and that's pretty rare where I spend over 75, but once in a while. the cock ring, yeah, okay. Yeah. All right, but critical care, 4.5 RVUs. That is a lot. So each critical care patient that you see is making you $62 more or less, okay? What's that? On top of it. That's like a billable, these are like billable procedures. So yeah, so going back to the level 4, level 5, all this stuff is added to that. Yeah. You can count trauma. If you actually think that you did more than 30 minutes of critical care in the trauma, you can and should bill that as critical care time. A lot of traumas where they're like kind of silly, I don't actually bill it because I'm honest, but you would probably be justified in billing some of them that I don't bill for critical care time. Yeah. Yeah. So you could, but it's going to be a stretch if they're only in the department for 10 minutes. Right, that's what I was going to add. So critical care counts documentation time. And since you guys document for hours, you could probably bill critical care time on pretty much everything. But I personally, if a STEMI is, I just see the EKG, I call the cardiologist, and they go up to the cath lab, and that's really all I did. I was with the patient for like 2 minutes. I don't bill critical care time. But if it's like, their blood pressure's a little low, they need to get a little bit of fluids, reassessing them, wait, is it an aortic dissection, spend a little more time with them, I'll bill that as critical care time, all right? So if you build every STEMI as critical care time, even if they're in the department, you probably would get away with it. But I recommend that you do the honest thing. If you think you spent more than 30 minutes on the patient, bill it as critical care time. If you don't, you shouldn't bill it as critical care time. But the time that you document does count towards the critical care time. The time that you document, yeah. Shoulder dislocation, probably too much. Too many RVUs for orthopedic procedures in general. 3.53 is $48.54 just to reduce someone's shoulder. Yeah. All right. IND of abscess. Abscesses are divided into simple, intermediate complexity, something like that. But a small one is not that much. This is 1.22. It's going to get you $16.78. Endotracheal intubation, I think, should be much higher than this. This is the most dangerous procedure we do. It's only 2.33 RVUs. So, yes. So probably if you're intubating someone, they'll have critical care time, although not necessarily, right? So one thing I didn't mention about critical care time is it's separate from billable procedures. So if part of your 35 minutes of critical care time was 10 minutes spent doing the intubation, then you're down to 25 minutes of critical care time, all right? So most of the time, if you're intubating them, you're going to do critical care time, but that doesn't necessarily mean you're going to have enough critical care time just because you intubate them. Probably you will, okay? Yeah, I'm going to talk about the anesthesia on the next slide. I'll just give you the brief part. Procedural sedation bills separately for procedures. So you do a procedural sedation and a shoulder dislocation reduction, 2 separate procedures. Each gives you RVUs. So that's very lucrative to sedate somebody and do a shoulder dislocation reduction, which frankly to me is like super easiest procedure we do, and I make a lot of money off it, so fine. Yeah, yeah, I'm putting a sling on them. Separately though, here's what kind of sucks. The intra-articular lidocaine block gives you nothing. Yeah, it gives you nothing, okay? So, all right. We got to keep moving. I'm way over on time. All right. Those were some common ones. Here are some interesting ones. Fecal disimpaction, which they call online remove rectal obstruction, 3.19. That's $43.86. Yeah, go for those fecal. I got to make a point here. Finding these numbers is difficult. I wanted to be like, work RVUs for intubation. Type it into Google. You expect the answer to show up. It doesn't. Here are 2 websites if you ever want to try to look these up on your own that actually have these information, okay? They change a little bit from year to year, but they don't change dramatically. All right, a few more interesting ones. Smoking cessation counseling. So I see some people clicking this. By the way, that's only $3.30. But I see some people clicking this. The reality is you have to counsel for at least 3 minutes to get smoking cessation counseling. I don't think I do that very often. I usually say stop smoking. That's like 5 seconds, right? So, yeah. So I have checked this a few times, like if I have a bit of a discussion with them about smoking, but in general, don't do this in the ER. And it's okay. It's not a super high billing procedure. If you're not checking that, it's okay. But please don't, every person who smokes, say that you did this, because there's no way that you're consistently spending more than 3 minutes with those patients, okay? There's also one that's more than 10 minutes, which bills more. There's no way in hell that you're ever doing more than 10 minutes of smoking cessation in the ER. All right. This is the one I wanted to show you. Pulse ox is listed on there. It's 0.00 RVUs, which of course corresponds to $0. So, yeah. I don't know why it's listed on the list of procedures, but then it's 0. Now this is the one we talked about before, the rhythm interpretation. It's called Rhythm ECG Report. That's what it's called on the official list. And it gets you 0.15. So $2 just to say, looked at the monitor and saw there were sinus tachycardia. Clemens. This is an important one since this is a push for it. Femoral nerve block, I'd group fascial iliaca block into this because fascial iliaca block's not listed, so I'd call it a femoral nerve block for RVU purposes. It's 1.5. That's going to get you $20, $20.63. Now, if you did a femoral nerve block for the purposes of draining an abscess on the thigh, which you could, it would be interesting, you get nothing, okay? So if you do a nerve block as part of another procedure, you get nothing. But if you do a nerve block simply for pain control, you can bill for it. You see how that works? This is why for shoulder dislocations, you're sort of de-incentivized to do an intra-articular block because you're not getting paid extra, but you still have to do the procedure. It's bundled into the procedure RVUs. So this is a little bit unfortunate. I think it should be changed, but I don't control this. Digital nerve block, again, so if you do a digital nerve block so that you can reduce a finger dislocation, you get nothing extra. But if you do a digital nerve block because they have a fingertip amputation and they have a lot of pain, you get 0.75 work RVUs, which is $10, $10.31. Yeah. This is the last slide, okay? We can talk about AMA for a whole separate lecture, but Anna was supposed to do a documentation lecture that got canceled, and she was like, can you include something about AMA in your talk because it's complicated? Yeah, it's very complicated, and I included more basic stuff in here since I didn't get that talk last week. Let me just say a few closing comments about AMAs. Number one, if you want to sign the patient out AMA and you really think they should go AMA, then your first job is to not let them go. Because if they leave, regardless of what you have them sign or what you document, that is much higher risk. So if you ever have a sick patient like a septic patient with a lactate of 5 who leaves, it doesn't matter what you document. You're going to be hosed if that patient leaves and then they die. So you need to do everything in your power to prevent that patient from leaving. And AMA is high risk. Them signing the form absolves you of nothing. So when I have those particularly sick patients who leave, then I get other family members involved. And I'll say, look, your husband is doing something that I think is very dangerous. I'm concerned he may go home and die. In many cases, the family member will then be able to convince them. But if they still don't, and the family member's like, sorry, he's just being crazy, I'll have the family member sign the AMA form too, and I'll document, also explain to the wife who also agrees that her husband is acting like he is just being reckless, but he has decision-making capacity. He's always been like this. He's just stubborn. It's like I'll quote the significant other if they say something along those lines. Okay. So number one, if they really, really need an AMA, don't let them go AMA. Now, if the patient is like some borderline low-risk chest pain, you're like, I don't really even know if I care if they stay. My personal preference is not to even have those patients sign an AMA. Because if I was in their position, I'd probably do the same thing that they're doing. Like, I don't want to be admitted if my chance of acute coronary syndrome is 0.2% or something, right? That's a waste of time and money. But we often recommend those admissions sort of just to CYA. So what I'll do in that case is simply document that I had a shared decision-making discussion. Patient reports that he understands that the risk of acute coronary syndrome is not 0, but low, and is willing to accept the risk, which could include death or disability should he go home. And I just leave it at that. I don't have them sign an AMA form. So the ones I have them sign an AMA form are where I really think that the patient has done something that is wrong. Like their choice to go home is dangerous, and despite all my attempts to get them to stay, they won't stay. So how do you document this? This is a rare time when I think that the pre-populated stuff in Meditech is pretty good. It might be because this is a corporate hospital, and so they've learned how, like probably a lawyer wrote this. This is longer than what I would ever write. It includes everything that I would write in my AMA stuff. It probably includes more than you need to write, but to go through it briefly, the patient has decided to leave our facility against medical advice. I have assessed the patient's ability to make an informed decision, and it is my opinion that the patient has the medical decision-making capacity to comprehend information regarding current medical condition and appreciates the impact of the disease or condition and the consequences of various options for treatment, including foregoing treatment. So if you ever are going to free text in a AMA note, you always want to document that they have decision-making capacity. They've written this in a long way. I'll often say the patient has decision-making capacity. I'll just write it as such. So that is an important part of this. Continuing, let's see. The patient possesses the ability to evaluate all treatment options, compare the risks and benefits of each option, communicate choice in a consistent manner over time, and is able to make rational choices. I don't usually write the rational choices because humans are often irrational, and I don't think that necessarily makes them have to be held against their will in the hospital. But another thing to document, in addition to they had decision-making capacity, if you're going to free text in an AMA note, is that you gave them another option. For example, the low-risk chest pain patient, they don't want to be admitted. Are they willing to stay for a repeat troponin? I'll often ask them that, and oftentimes that they will. All right, and that's a very reasonable thing to do. It may suck for your numbers. Dr. Averbach might not be happy, but that's the right thing to do for the patient, rather than send them home on one troponin, which might be a little bit risky. Ask them if they're willing to stay for a second troponin. Give them another option, and document that you did so. I have explained to the patient further testing, treatment, and evaluation I would like to perform during the current emergency department visit, as well as any possible alternatives that could be accomplished in a timely manner. That's exactly what I was saying about the repeat troponin. I've outlined the possible risks of foregoing any or all these interventions, and the patient understands and acknowledges that the decision to leave may result in undesirable consequences such as death, permanent disability, and or loss of current lifestyle. So that's the third thing. In addition to saying they have capacity, in addition to saying you offer them an alternative, you want to say that you specifically mentioned that they could die from this and that they could be disabled from this. Sometimes that is very dramatic. If they're leaving AMA because they have low-risk chest pain. Again, I don't usually AMA those patients. I just shared decision make those patients. But if they were, the chances of them dying is exquisitely low, but I guess it's always possible. Okay? But you want to be able to say and document that you said that they could die from this and they could be disabled, because it has been in lawsuits where they've documented that they said they could die, but they didn't say they could be disabled, and then the patient's like, this is worse. I'm disabled. This is worse than dying. So you want to say both of those things, death and disability. Finishing up, even though leaving AMA is not ideal, I've instructed the patient to follow any discharge instructions given, take any medications prescribed, and resume care as soon as possible with another provider. Additionally, we clearly say to the patient is welcome to return at any time to continue care at our facility. And this is the last component of any good AMA, which is that even though they're going to go home and you didn't want them to go home, you still give them treatment. If you wanted to admit them for sepsis and they want to sign out AMA, you still give them antibiotics. Do not just give up on the patient. Do the second best thing you can think of. Do the best thing you can think of for outpatient treatment. Give them antibiotics or give them whatever they need that you can through outpatient prescriptions. And then I always write this last part, patient is welcome to return at any time to continue care at our facility. I write that on the discharge instructions for someone who's leaving AMA. Return to our facility at any time if you decide that you want further care. I specifically write that on their discharge instructions to let them know and to let someone else who looks at this say that I wanted them back. You can come back anytime. I'm not going to be mad. Okay, that's the end of this lecture. Sorry it went long. I'm going to tell you the last key points. Number one, you can free text or click box your notes. That has been demonstrated. That's what the director of clinical documentation said for Envision. You can do either. Do not spend your time putting the same information both in free text and the click boxes. You're wasting your time. To get a to get a level 5 chart, 10 systems. To get a level 5 chart, 9 systems. In some cases, it's 8. Just do 9 to cover yourself. Avoid duplicative information in your MDM. We went through that in detail with several examples. A lot of what you're writing in the MDM adds nothing to the chart. Document procedures assuming there will be a complication. It is not acceptable to write paracentesis done, laceration repaired done. Okay? Assume that that patient is going to have a perforated bowel from their paracentesis. Do the procedure in a way that that won't happen, but one day some bad procedural complication is going to happen to you, and you want your procedure note to look like you were very careful. Okay? That's it, guys.